Distinguished Chairman, moderators, and colleagues, the Lawson retrograde nephrostomy system made by Cook Medical involves positioning a ureteric catheter into a selected calyx with a deflecting wire. The puncture wire, seen at right, is then advanced retrograde through the catheter and out the flank to complete the nephrostomy. Prior to the CT scan era, urologists were unsure about adjacent organ location. Now with CT review, we can predict a safe tract. Our friends in Winnipeg, Canada recently reported on 319 cases, 52% of which were upper pole access. Last year, Dr. Alutabi reported on 76 upper pole retrograde nephrostomies. In 1989, Dr. Larry Munch deployed the puncture wire through the working channel of a flexible ureteroscope. We further developed this technique and present this to you today. Patients are placed in the modified lithotomy position with careful padding. The flank is elevated with folded sheets. This position has many benefits to anesthesia, surgeon, and patient, as listed here. We begin with flexible ureteroscopy. We typically use the Storz Flex X2. Pressure irrigation causes ballooning of the renal pelvis, permitting scope movement. Selection of a posterior calyx is facilitated with the endoscope. The puncture wire ensemble is advanced. The wire often just tents the skin. We incise over the wire, which is then carefully drawn out. We require that the punctures emerge behind the posterior axillary line, and we usually re-review our CT scan intraoperatively to ensure that our tract is safe. To exchange the puncture wire for a standard working wire, we use a 5 French coaxial catheter with a tapered tip. No separate incision of fascia or renal capsule is needed. The coaxial catheter is advanced over the puncture wire into the ureteric access sheath. We then remove the inner coaxial catheter and puncture wire. Our working wire is introduced into the outer catheter. This view is inside the access sheath, looking up as the wire comes down. The wire emerges at the penis. The ureteral access sheath is removed and reloaded onto our safety wire, which is imaged here. The ureteroscope is reintroduced through the access sheath, and our nephrostomy balloon is positioned and inflated under endoscopic vision, sparing radiation. How do we plan our cases? We study our CT scan and select the exact calyx optimal for puncture. Here, the upper pole calyx is unsafe due to the spleen. The mid-pole calyx, however, is well away from bowel. Calyx selection is verified intraoperatively with retrograde pyelogram and endoscopic orientation. Further, the renal pelvis to calyx angle will predict the firing trajectory of the wire, as seen here and here. A posterior trajectory of the ureteroscope can also be confirmed with angled fluoroscopy. Note that in the CT scan era, no adjacent organ injuries have been reported in over 454 cases of retrograde nephrostomy. Because our punctures are at the level of the papilla, we estimate a reduced risk of injury to the interlobar artery. We have been successful in 29 out of 33 cases. 2 patients had both morbid obesity and hydronephrosis. The wires did not emerge at the flank. 2 early tracts were not dilated after intra-op CT review revealed nearby pleura and spleen. After these cases, we instituted a pre-op CT review. We have no nephrostomy-related complications. There are now 274 reported cases of upper pole access using retrograde nephrostomy with no reports of organ injury. Here are 3 of our upper pole cases. This patient came to us after interventional radiology failed twice to obtain upper pole access using a concerning 78 minutes of fluoroscopy time. A first attempt at UARN by our urology fellow succeeded after 90 seconds of fluoroscopy. We believe UARN is ideal for accessing a stone-filled calyx. The irrigation pressure will often balloon the collecting system to allow navigation, as seen here. Alternatively, we laser the stone until we reach the papilla. In our experience, 1 in 4 patients required lasering. Our mean BMI is 30. Here is a failed case. The wire is supported through the kidney and muscles. However, subcutaneous fat does not support the wire, and the wire often bends. A straight horizontal tract will often succeed in these patients. Our Winnipeg colleagues exclude patients with significant hydronephrosis from retrograde nephrostomy. We succeeded in 4 of 6 patients with SFU scores of 3 or 4. Here is a failed case. When the wire is advanced, the scope moves and the angles all change. Here we see movement in a dilated system. We estimate our learning curve to be less than 5 cases for competence and about 15 cases for expertise. Over the past 2 years, our interventional radiologists have used a mean of 12 minutes of fluoroscopy time to create nephrostomies for PCNL. Our mean nephrostomy creation fluoro time is 22 seconds. Applying a dose formula reported by Lipkin et al. From Duke University, we estimated the case-by-case dose exposure to our institution's IR patients and our UARN patients. For reference, Balanov estimated the lifetime risk of cancer induction from a single 10 millisievert dose exposure by age and sex, shown here. The European Commission set a maximum radiation exposure of 20 millisieverts per year for radiation workers. Here are the 3 lowest nephrostomy creation fluoro times in our series. We believe that UARN has benefits over the traditional Lawson technique, those being more confidence of a posterior calyx selection, ability to laser an obstructing stone, and direct vision balloon placement. In summary, the retrograde nephrostomy and our ureteroscopy-assisted retrograde nephrostomy modifications have a good safety profile, ease of upper pole access, and stone-filled calyces. Morbid obesity and significant hydronephrosis are relative contraindications. No special equipment is needed other than a flexible ureteroscope. UARN has a very short learning curve and virtually eliminates ionizing radiation. We believe that retrograde nephrostomy is an excellent technique for a non-dilated collecting system. We hope for external validation of our results. Thank you so much.